So you get a specimen down the lab, you're not sure what's causing an infection, the lab grows it up overnight, they have it on an auger plate, they put it on a gram stain, put it on a slide, and what does the lab tech see?
Blue and purple.
Clusters.
Interesting. Okay. Gram-positive cocci. If it's, let's say, strep pyogenes, it is in what arrangement? Or most of these streps are going to be in what arrangement?
Clusters.
Not clusters.
Oh,
They're going to be in chains
chains.
mostly. Clusters would be
Delete
more
that.
like what?
Staff.
Staff.
Swing and a miss.
There was one species of strep that doesn't. Very good in that. Okay, so Streptococcus pneumoniae is oftentimes in pairs. That's right. So that's pretty good evidence that you can do a really quick, rapid test just to make sure that it is indeed Streptococcus. What would be the first test you would do? Catalase, that's right. So do most strep species possess the catalase gene? No, they're catalase negative. Good. Okay.
Rapid strip first.
Okay. So that we will pick up on this slide and talk about how this most virulent member of this genus, it's called Streptococcus pyogenes, establishes infections. So the pathogenesis of strep throat first, and then we'll talk about some other infections that can be caused by Streptococcus pyogenes or Group A strep. Oh, speaking of Group A, let me back up and do one more review topic that I didn't hit. What is Group A? What does that mean? What's the significance?
Is it the enterotoxin? Is that the toxin it has?
Mm-mm.
No.
No, I'm thinking about something in the cell wall.
Polysaccharides.
Yeah, it's a C substance in the cell wall. So just because it's called a C substance doesn't mean it's all Group C, right? It's Group A, Group B, Group C. It's an antigen that's in the cell wall, and you test for it. It's another rapid test to do, very cheap, very easy, very quick. Use anti-sera, get that colony, grab some anti-sera, and see if you have a positive reaction or not. If it's not Group A strep, that anti-sera is not going to have that visible clumping reaction. Simple as that. Okay. So Group A strep, and then these colonies, as you observe the colonies on that blood auger plate, they will show a hemolysis pattern. What is that hemolysis pattern?
It's a beta?
For strep.
So what are they? What are the three types of hemolysis patterns? Let's start there.
Alpha, beta, gamma.
Alpha, beta, gamma. Alpha looks what? It looks like what?
Partially.
Sure. Yeah, and it has kind of a greenish discolored look to it, right? Okay. Okay, so complete hemolysis of those erythrocytes in the media. Okay, and then gamma. Nothing. Okay, so of those three hemolysis patterns, Group A strep will have which pattern? No. Beta hemolysis, total hemolysis of those red. So Group A beta hemolytic strep is characteristic of Streptococcus pyogenes. Make sure you don't conflate the hemolysis pattern, which is an indication of what kind of hemolysis it's producing, with the Lancefield type. That's something that's an antigen that's in the cell wall. Okay. So I'll keep hammering that. It'll be second nature. Okay. Yes, sir. Yeah, so that's a good question. This chart right here, a lot of your strep species are going to have that antigen present. The ones that don't, though, doesn't mean they're not pathogenic, doesn't mean you don't need to know them. It just means that there are some that belong to like the Viridans group, for example. They don't have a group. So as that lab tech is sitting there going through these anti-sera, which look like this, right, these little commercially available reagents, if they go through all of them and nothing is positive, it might be one of those untypable groups, like the Viridans group, which we'll spend one slide talking about. And on that note, for Enterococcus, we talked about Enterococcus just a little bit with the Lancefield groups. Is that the same genus or a different genus than Streptococcus? Different genus, and it has what kind of Lancefield grouping characteristic? D. So Enterococcus species, we'll hit that too, but that happens to have a group D antigen in the cell wall. Okay, so back to Streptococcus pyogenes, group A strep. We said that we were colonized with these. This smaller percentage of people are colonized with group A strep than there are with Staph aureus. But still, a sizable number of people, perfectly healthy, carry this mostly in our nasopharyngeal tract, like back in our nasopharynx, in that area. So that's fine, but it does kind of predispose you, especially if you have a strain that has some of these more virulent factors on it, it predisposes you to getting things like throat infections, especially if you're younger, because age matters a lot with strep throat. So what happens in this pathogenesis is, as we'll see on the next slide, there are some attachment factors that Streptococcus pyogenes has, as it's trying to bind to and establish colonization in the back of your throat there. What it needs to be able to do is adhere to that mucosal epithelial surface. So that's step one, and even that is not necessarily causing any pathogenesis or issue at that point. What determines whether or not you progress to developing sore throat or not is whether or not those bacteria that are now attached to those epithelial cells are able to replicate rapidly to appreciable numbers. If they aren't, if they're slow replicating and the immune system sort of taking care of them and they're getting destroyed at a rate that the body can keep up with, you probably won't get an infection. But if they replicate fast enough, it will reach this critical threshold and you will get an infection at that point. So they'll replicate, they will start invading the mucosal surface because they're elaborating some of those toxins that have lytic properties. So they're starting to cause a little bit of destruction themselves just by virtue of their exotoxins. And once that mucosal surface is damaged, they can invade a little bit. They're not intracellular, so keep in mind they're not going into those epithelial cells. They're just softening up that tissue, doing some damage so they can get deeper in there. This is when your immune system gets pissed off. You have a whole bunch of immune cells located in your MALT, right, your mucosal associated lymphoid tissue. So when those immune cells, those innate immune effectors particularly, when they sense that they have bacteria that are now invading that mucosal surface, you get an immune response. And then that immunopathology is like a pile-on top of the damage that's being done by the bacteria itself. So some of these symptoms right here, the influx of WBCs, we've talked about that before, that causes some damage. The fluid leakage causes damage. Pus formation causes damage. So all of that is going to contribute to the symptoms that we talked about in a couple slides. That is strep throat, basically. That's what it is. And the symptoms we'll talk about are consistent with what's happening with that amount of damage. It usually resolves within a couple days, but it is possible that that type of infection, particularly if you get that invasion of the mucosal surface, it can get into your bloodstream and cause bacteremia, which could possibly lead to something like, what do you think?
Sepsis.
Could possibly cause sepsis. Or, if it gets into your bloodstream, it could seed distant sites and you get some of these infections that otherwise you'd be scratching your head about how this colonizer of your nasopharynx would end up causing bone disease or pneumonia or destruction of muscle or any of these other deeper tissue infections. Going over some of these virulence factors, there are two slides that will cover these virulence factors. The first slide is talking about some of the ones that are on the outside of those bacterial surfaces. And hopefully these ring a bell. The capsule, of course, is important, hugely important. We know that. It has a special kind of capsule. It's something we haven't talked about yet that's composed of hyaluronic acid. What do you think your immune cells are going to do when they see hyaluronic acid instead?
Hyaluronase.
If they're well trained, they're going to leave it, like a well trained puppy, right? Just leave it. So you don't want them attacking those cells. And because of the fact that they're coated with this hyaluronic acid mimic molecule, they do a pretty good job of escaping immune detection. That's a major virulence factor of strep pyogenes. So they have that going for them. It also makes it harder for those phagocytes to engulf them. And the cell wall itself, so on this diagram, that would be that yellow portion. That's the cell wall underneath that purple capsule. In that cell wall, you have M protein coming embedded in that and coming out, extending up through the capsule. That M protein is important for making sure that complement doesn't deposit on the surface of those bacterial cells. So that'll impede complement system from functioning properly with that M protein. But that is a double-edged sword for these bacteria because the M protein very immunogenic protein. We've learned this, right? If it's on the exterior of those bacterial cells, it's accessible to antibodies. So antibodies will see the M protein, and it's protein, so they bind with high affinity to it. They'll see that, and you raise an adaptive humoral immune response to these. That's the good news. But the bad news is we have over 150 different types of M protein strains. So you raise immunity to one strain, unless you get reinfected by the same strain that expresses the same type of M protein, those antibodies that you previously raised will do nothing for you. They're not cross-reactive. Because of that, you are prone to getting recurrent infections of strep pyogenes throughout your life. You don't get a really good protective response against that particular M protein producing strain. But it will help clear up the current infection you have. The fact that it's immunogenic. Yeah, Jesse. Wait, sorry, did you say that again? Yeah. You can definitely call those people carriers. If they're just walking around colonized but not having any symptoms themselves, that's the definition of a carrier. And then the last feature when we're talking about the features of the cell wall that contribute to virulence for herpes strep is this protein F. It's just another attachment protein. It's also a bit immunogenic, not as much as M protein, but all you need to know is that F it binds to fibronectin, FF. So that's important. And one other feature, the C5a peptidase that is not quite transmembrane, but it's membrane associated. That is a peptidase that gets kind of sloughed off. Some of it gets sloughed off from the cell and released, and some of it stays associated with that bacterial cell. But what it does ultimately is it binds to C5 alpha and it prevents recruitment of some of those immune cells. So it impedes the function of the complement system, C5a peptidase. Now, the toxins. There are a lot of toxins that strep pyogenes produces, and knowing these will give you a better appreciation when we start talking about some of the types of damage that this bug can inflict. Probably the most important one are these SPEs, the streptococcal pyrogenic exotoxins. Exotoxins, these things get secreted out of the cell, so there's probably some sort of secretion system that strep pyogenes produces. It's not the only one, but they're up here, pyrogenic exotoxins, so those are the SPEs. There are a bunch of them. There's SPE A, SPE B, SPE C, SPE D, whatever. You don't have to remember them, just know that there are a bunch of different exotoxins. And these guys are, unfortunately, your superantigens. So when you have strains that express SPEs, which are oftentimes carried on plasmids or on phages, one of the two, you're going to have some problems. You're going to have more serious infections. And those infections will be characterized by systemic effects, because we know that superantigens are a problem because they non-specifically bind to the TCR receptor and MHC class 2, right? So that's what we're seeing when we have expression of SPEs and those strep A pyogenes strains that produce them. It's like a big boost in virulence. That can bump you up from normal case of strep throat to scarlet fever, or it can lend itself to another type of toxic shock syndrome. This one is streptococcal toxic shock syndrome, just like we talked about staphylococcal. There's also streptococcal toxic shock syndrome. So systemic effects because of those SPEs. We also have two different important secreted exotoxins called streptolysins. One is oxygen stable, that's streptolysin S, and the other one is oxygen labile, streptolysin O. A couple of important differences there. It's actually just O that gets secreted out. If you look at that diagram, S is that red blob. It's staying membrane associated for the most part. But they have very different functions. Since S is mostly going to be membrane bound, it acts by close contact interactions with host cells. It has a pretty wide number of host cells that it can affect. Leukocytes, erythrocytes, and platelets, that's pretty broad. But it's not as broad as streptolysin O, which has the ability to insert and lyse all sorts of different cells. So it's non-discriminating streptolysin O. There's also and by the way, guys, these streptolysin are since they can lyse things like red blood cells, they're responsible for the beta hemolytic pattern that we were talking about, strep pyogenes, both of them. They also have different levels of immunogenicity. The streptolysin S, the one that stays associated with the cell membrane, kind of intuitively doesn't elicit that much of a humoral response. The one that is secreted acts like any other exotoxin, and it's highly immunogenic. So you do raise a lot of antibodies to that secreted one, streptolysin O. Those antibodies are called anti-streptolysin antibodies, or ASO, and those are a very important diagnostic tool. If you want to look to see whether or not somebody's had a recent infection with strep pyogenes, you could look to see if they have those ASO antibodies. So that's important as well. These last two factors just have specific names, but they're things that we've talked about in the past. Streptokinase is a type of fibrinolysin, so it's going to function like any other fibrinolysin. It's going to help those bacteria get out of the clots and aid in dissemination. And then with the streptodornase, that is a type of DNase. We've talked about DNase as being able to kind of thwart or counter the action of nets released by neutrophils. But with these guys, since these are associated with pussy, purulent infections, these streptodornases will allow those bacteria to, when they're secreted, to cut through some of that pus material, because a lot of that stickiness is extracellular DNA, eDNA. Okay, so that's another important virulence factor and allows those bacteria to get out of the pus that would otherwise trap them locally. There is a mnemonic device. I'm sure you guys have different sources you go to for handy, steady mnemonic devices. This is one that is a little flawed, but I do like the way it flows. Smashed. Take it or leave it. Some of it's tortured against C5 alpha peptidase is a little, whatever. But if it's helpful, it does capture a lot of the major virulence factors with strep pyogenes. All right, so we know what the virulence factors are. Let's talk about the primary disease that is associated with Streptococcus pyogenes, with herpes strep. That is acute pharyngitis. With this disease, what you're looking there in the back of the throat are clearly there's some damaged tissue. You can see some red spots where looks like there's been some like local tissue damage back in the back of the throat. Looking at some of those symptoms, you've got, if it gets bad, rapid onset of fever. And that would be toxin mediated probably. A sore throat, so the throat itself is going to hurt. If you've ever had strep throat yourself, you remember how painful it is to swallow. That's called dysphagia, when you have difficulty or painful swallowing. Swollen lymph nodes, cervical lymphadenopathy, so usually like in the front of your throat there, those will be extremely swollen. Exudative tonsillitis, if you look back on the back, that means that there's an exudate or kind of like a pus that's being generated from that tissue that is being infected and it's being destroyed. And some of those, when they get really bad, it's not really evident on this picture, but you can see streaks of white pus on the tonsils and on the uvula back there. We talked a little bit, just bumping up back to the top, about those central criteria before and how you use them to evaluate patients. The age, like I said, it is important. You get points deducted if you are over the age of 15, and more points deducted if you're over the age of whatever. I'm not that familiar with them. But age is important. This primarily affects kids in the age range of 5 to 15. You also you're evaluating the patient's symptoms as well. So one thing that counts against this being strep throat would be if the patient is coughing. If they're coughing, it's probably not strep throat. Why do you think that would be? Yeah. So there are a couple viruses that are associated with sore throats, but most of the pathogens we think about that affect, that affect the upper airways are going to cause coughing, but this doesn't, and that's because it's going to be localized in the back of your throat, posterior oropharynx. So coughing would be an indication that it's probably something else other than Streptococcus pyogenes, not strep throat. Treatment in this case would be important, and that's because you want to prevent some of those sequelae that aren't associated with the infection themselves. We'll talk about those more in a bit. But if you have a strep throat infection, not only do you worry about the sequelae themselves, but those bacteria can also spread into the ears. You can get otitis media, which is an ear infection. You can get sinusitis and other head and neck infections as well. The more serious form is scarlet fever. This is when you have a strep throat infection, but the strain that is infecting you has those superantigen toxins, so it's carrying those. And because of that, you get some of these systemic effects, like a full body rash. It looks like a sunburn. If you have been out in the sun and you get a full body rash, you might have scarlet fever. There are some other particular symptoms too that are unique. That rash itself has a unique feel to it. It feels like sandpaper. The papilla on the skin are really, really rough, so it's very distinctive. This does happen a lot of times in kids. The rash itself can be difficult to see, especially if your patient has darker skin. It can be difficult to see, but that characteristic sandpaper feel of the rash is a telltale sign that you're dealing with scarlet fever. Some other features, like this cartoon of this little girl or boy, I don't know, creepy looking kid. You can see that full body rash. It'll start out usually on the chest or on the torso, and then it'll move out, so it'll go on the face and on the extremities eventually. You can also see these lines and the creases like around the shoulder joints and around the inguinal area. Those are called Pastiel's lines. And those are where the capillaries are starting to break a little bit, just around those high friction areas. You get some extra deep red rashes in that area. Another unique feature symptomatically would be some of the oropharyngeal signs, and those change over time. Early on, you get this white strawberry tongue, which you can see in that picture there, where the kid basically has like this layer of mostly like dead cells on their tongue, and then you can see the red of their taste buds, whatever, popping out. So it looks like a white strawberry. Over time, that white layer will slough off and it'll become a red strawberry tongue. Moving back into skin and soft tissue infections. So we'll start with impetigo. We've talked about that with Staph aureus. Usually when you have a kid who's coming in with impetigo, and this is primarily going to be affecting kids, it's going to be caused by one of those two bugs. It's going to be Staph aureus, impetigo, or it's going to be Streptococcus pyogenes, usually. It is virtually impossible to tell the difference between those two etiologies by just looking at them. But if you are concerned, you can always, take a bit of that crust and send it off to lab, and the lab can grow the organism from those pus samples. When those are developing, usually they start off as just like little raised bumps, and then they become vesicles. And then those vesicles become pustules that have pus in them. And then when that bursts, you get that honey-colored crust that forms. So there should be organism in that to culture. Erysipelas are a much more serious infection. A couple pictures of erysipelas on this slide as well. We talked about those briefly, and we're talking about staph, which can also cause erysipelas. The features are the same between the two etiologies. We were talking about, and this really shows it nicely, we're talking about a very well-defined, demarcated red area, erythematous area, hot to the touch, swollen a little bit, and you can see, this tends to happen more frequently on the face or on the lower limbs. Both of these pictures, you can see a gentleman with erysipelas extending over his cheeks, and then somebody who has it on their calf as well. So that is indicative that there's an infection going on underneath the surface of the skin and the upper layers of the dermis. If you wanted to, so this is probably going to require antibiotics, but the skin is intact most of the time, right? You might have a lesion, you might not, but if the skin is intact, how are you going to get a specimen for the lab? What would you send off? Just like swab the skin? You could be just a carrier though, just a normal healthy colonizer. So like, let's say I'm a person, like you've got a pretty alarming, concerning erysipelas on this person's lower calf, and the organism is down there. What else can you do directly? Yeah, so you can do a couple things. If there's fluid in there, if there's bully, which sometimes there are, we talked about bully, right, being those blisters, you can aspirate that fluid off. And that would have it, because we're talking about a legitimate infection. This isn't toxin that's being released, it's like an infection. Or you could do a skin biopsy as well. But if you try and just swab the skin itself, even if there's a lesion, that's a low yield specimen with very low chance of recovering organism. The bacteria are going to be there, and they're going to be underneath that intact layer of skin because it's an infection of the upper dermis. Yeah.
Wouldn't you want to leave the skin intact though, because that would just induce more?
Yeah, I mean, but you are going to need to treat this, and you do need to know what the organism is to treat it properly. This comes down to skills that you're going to learn in IPAP, hopefully, but really good technique in making sure you're not introducing bacteria, like endogenous bacteria, into that area or exogenous bacteria. Keep it clean, keep it as aseptic as possible, but you need to get that specimen to the lab to go on antibiotics. Yeah. So they can. There's a pathway, in at least a couple different pathways. One is you get some sort of penetrative injury, and you get a localized infection that way. That's very common. It could be a surgical site infection, it could be a splinter, whatever. Break in the skin, and you get something like this, erysipelas, in a normal, healthy person even. The other pathway is when you have a colonized carrier who has it back in the nasopharynx, and you get an infection and like a break or loss of integrity in that mucosal area, and it gets into your bloodstream. And then that can seed a site very distant from the throat itself. You could be looking at an erysipelas on the calf that started off here. Okay, now finally we're looking at like a nice cross-section of what the skin looks like, so we can talk through some of these skin infections a little bit more specific terms. But first let's talk about cellulitis, which is one level more serious than erysipelas. We've gone even deeper now. The irony is that if you look at this picture of a person with erysipelas also in the lower limb, it doesn't look like it's as bad as the cellulitis. It doesn't look like it's as bad as the erysipelas, but it is worse. It is deeper, and the damage is more significant than what this image would suggest. This would be very painful. It is going down to past the layer of the dermis just before the fascia. So if you look at this picture there, here's the fascia. This is just before you get into the muscles. We're talking about an infection here, kind of in this area, and the bacteria all the way down there in this area. And they're spreading outward, they're replicating, and this infection can get pretty bad. It can advance from cellulitis to one of the infections we're going to see on the next slide. So definitely you want to treat with antibiotics, possibly oral antibiotics, or maybe even IV antibiotics. But important to treat this, not just for the fasciitis, but this could also lead to bacteremia as well. All right, lastly we have necrotizing fasciitis and myositis. These are infections of the fascia and the muscle, respectively. This is when we have actual tissue death. So you'll see some things that they start looking like necrotic tissue. The strains of Strep pyogenes can cause this kind of damage, or sometimes cause, they're called flesh-eating bacteria. You may have seen that sensationalized in the news before when you hear about cases of flesh-eating bacteria. But this is one of those that has the capability of causing that kind of damage, where it just destroys the deep layers of the skin and deep into the fascia and into the muscle as well. With necrotizing fasciitis, you have those bacteria growing on the plane of the fascia here, and then they replicate along that plane right there. They can always progress to become, to infect muscle tissue even deeper, and then you have myositis, that progression there. In either one of these cases, since we're talking about a spreading disease and it's necrotic tissue, these are medical emergencies. They have to be dealt with immediately. Antibiotics are probably not, you'll put somebody on antibiotics for sure, and it's going to be like broad spectrum, holy shit, antibiotic type situation. But this oftentimes also requires and necessitates surgical debridement to get rid of the infected necrotic tissue. It's very urgent that you do that. Sometimes amputation is required. Very serious condition. A couple pictures of first necrotizing fasciitis. The patient reported extreme amount of pain. That's another feature. The pain is out of proportion to what it looks like it should be. It looks like they're messed up their foot, sure, but it's not like this person could die, right? Until they start doing surgical exploration, fasciotomies, take a look to see what's going on, and they see that there's extensive tissue damage. And they've got to breed all of that down, look how much tissue has been removed from that. And then the picture on the bottom there, again, just another type of, another patient with another case of necrotizing fasciitis. But a lot of that is due to those exotoxins that are destroying cells and tissues. Here we see the other, yes sir?
Would this be like some sort of progression, or would they present on the left, the website?
It could progress. There's a case study on this guy in the notes. If you have the PowerPoint, it has a link to it. And oftentimes but this is like as bad as it gets. The guy was already presenting with really life-threatening necrotizing myositis. But oftentimes they do progress from erysipelas to cellulitis to necrotizing fasciitis to necrotizing myositis. And it really, like, anytime you get bacteria into the bloodstream, then you can get bacteremia as well. So that can happen at any point when that bacteria starts getting into the bloodstream. So septic conditions. Yeah. Fast. Well, it depends on the case by case and patient by patient, but this is why it's good to read case reports. I encourage you, not that you have a ton of time or you want to spend your 4 day doing this, but this link to this particular write-up in the Scandinavian Journal of Trauma is an excellent write-up about the time course of when this patient presented. It has a couple different patients, I think, but this guy, let's see if I have it in my notes. Yeah, previously healthy, so he came in with no comorbidities, wasn't hospitalized or anything. Previously healthy, he had some sort of trivial trauma to the right foot. So you have a seeding event going on, and then within 2 days, he presents with sepsis. He's tachycardic, he has hypotensive, so he's already having these systemic effects, probably has bacteremia, and then in addition to this kind of tissue damage. It's a very rapid time course. When we talk about Clostridium perfringens, if you guys have heard of gas gangrene, that has an extremely rapid progression as well. It's very scary to see the rate of tissue damage with those. So yeah, with this guy, picture on the left there, that black tissue, that's necrotic. There's a notable absence of pus, so you're not even seeing any pus. There's a lot of, that's devitalized tissue, it's devascularized, it's just completely dead tissue. They had to do, that picture on the right is basically showing that guy's his bud. They did like a gluteal excision. They removed a big chunk of his gluteal muscle to try to get rid of the infection. See how deep that went, and then they had to sew that flap back up. And then they submitted specimens down to lab, and lab did a preliminary report just based on the whatever tissue specimen they got off of this thing. The gram stain, gram-positive cocci and chains. That was a presumptive. And then when they had the culture results ready, they set those up as well as the ASTs. The ASTs were, it was unfortunately at least a very susceptible strain of Streptococcus pyogenes, but that was one of the features in that article that was interesting too, is how they used information from the lab to treat this guy. Okay. I'm not, oh, yes.
You said the case report was in the Scandinavian Journal.
Yeah.
Does it, do your data mention where this case happened?
Yeah, I think it actually happened in India, and I think they submitted to the Scandinavian Journal of Trauma. But yeah, it's a really super interesting write-up. I'm sure you read it. All right, so we have talked about strep throat, we've talked about scarlet fever, we've talked about skin and soft tissue infections, and this is all still caused by Streptococcus pyogenes, mind you, for base strep. Now we're going to talk about puerperal sepsis. historically known as childbed fever. You've probably heard of this one before. It used to be like a major killer in of women, particularly after like shortly during delivery and after delivery, peripartum infections. And what this is oftentimes associated with you have these bacteria, Streptococcus pyogenes, that gets into the reproductive tissues right after childbirth. And right after a woman has delivered a baby, there's like, she is beat up, right? So those tissues are softened and susceptible to infection. It's one of the most susceptible times for infection. Historically, before we had good labor and delivery, good, aseptic conditions for labor and delivery, women used to die all the time from this infection because they would get the bacteria, it would cause an ascending infection and start destroying these reproductive organs like the uterus and the fallopian tubes, etc. And then you could become septic from there. It just continues to get into your bloodstream and cause sepsis. So major killer, you hardly hear about it anymore. You still have deaths caused, especially in the developing world, caused from puerperal sepsis. But we recognize it now. We know how it's caused. We know what the point source is. It's usually Streptococcus pyogenes, but it can be other bacteria as well, and it can be polymicrobial. But we've done a really good job in implementing good hygienic procedures during labor and delivery to minimize these cases. Anybody know who the fellow in the top is? Ignaz Semmelweis?
Dr. Childbed,
Dr. Childbed?
the childbed fever, they named it after.
Yeah, Dr. Childbed. Sure. No, this guy's like a hero in, yeah, Ignaz Semmelweis, yeah. So he was Hungarian. He had worked in Budapest, I think, in and around Budapest. In the 1800s, in the mid-1800s. Anybody know this story or familiar with it? Okay, real quick. Yeah, no, good job, Levi. A lot of deaths. But
People would go from surgery to giving birth without washing their hands, and a lot of them would die. The first one is radicalized. Dead bodies. Dead bodies.
yes, that's exactly right. Yeah,
They weren't cleaning up instruments.
No, it's the hands.
the hands.
It was like working on cadavers and then going to deliver children. And he had this crazy idea to wash your hands before touching the baby from the dead bodies. It was this radical idea, but then a lot of women stopped dying.
Yeah. Yeah, it's weird how that works. But this is before we knew about hand washing, right? So this was just based on pure observation. There's nothing, he wasn't a genius. He was just like, hey, at this clinic with these doctors, the highly trained, elitist guys who'd been through medical school in the 1800s, versus the midwives, right, who were doing nothing. The midwives were doing nothing but what? Labor and delivery, right? The doctors were doing autopsies in the morning and then going over to work in labor and delivery. So they were not washing their hands. They were working with, cadavers, dead people, and then going to L&D after that. And that was transmitting bacteria like Streptococcus pyogenes to these women who were then dying in huge numbers. And that was common practice. That was all over the world. Just this is where he made the observation that these midwives are only dealing with pregnant women, so we're not transmitting bacteria as much. And then also the hand washing reduced transmission of Streptococcus pyogenes from the providers to the women. And mortality rates plummeted, and this poor guy was still ridiculed, and they just laughed him out of relevance. So, in terms of transmission sources, though, that would be an example of exogenous transmission, where you haven't washed your hands and you're delivering a baby, and you're spreading the transmission to that woman. You can also get it endogenously as well, from the mother's own vaginal flora. That can especially after you've delivered a baby, that tissue can hang around and start being conducive to infections. Those symptoms associated with puerperal fever are consistent with septic conditions, high fever, chills, nausea, abdominal pain, tachycardia. All right, now we're talking about sequela. So, talking about things that have happened after the bacterial infection has been resolved. This first one is acute rheumatic fever. This is more associated with patients who have recovered from strep throat, and this is the reason why we prescribe antibiotics to treat strep throat, to prevent rheumatic fever. What happens is when you start developing antibodies, we kind of talked about this a little bit earlier in earlier blocks, but you develop antibodies against that M protein for strep pyogenes, and unfortunately those antibodies are cross-reactive to cardiac tissues. So you get direct damage from your own immune system on heart tissues and some other tissues as well. It can be cross-reactive and affect more than just the heart. But these symptoms are associated with things that you would link to endocarditis and problems with the heart. Much more serious disease than acute pharyngitis. This can be potentially lethal. And because there's no bacteria involved, diagnosing it can be tricky, right? Because there's no specimen to submit to lab. Any ideas what you could do for a little bit of lab support? Some better evidence?
Antibody?
Antibodies, yeah. What kind of antibodies? The antibodies against what?
Strep pyogenes.
Yeah, but we talked about the streptolysin and the ASO. Anti-streptolysin O antibodies are really valuable in cases like this. So, check to see if that patients have a recent strep infection and or if they have ASO antibodies, high titers of ASO. Another important sequela is acute glomerular nephritis. This is affecting the kidneys and specifically the glomeruli of the kidneys, the part of the kidneys that actually does the functional filtering. So the symptoms here are associated with what you'd expect when you have a lot of kidney damage, loss of kidney function, swelling, weight gain, lethargy. I'm trying to see if there's any symptoms that we haven't really talked about yet. What about the hematuria? What is that? Right, so then you would have some erythrocytes getting into the urine and causing it to be off-colored. This typically could be associated with either pharyngitis or impetigo. Harmless impetigo infection could cause this. Other features, it tends to develop later if the person was preceded with impetigo infection relative to pharyngitis. And it's not as preventable as rheumatic fever is. So you can treat aggressively, and unfortunately those immune complexes, when they form, they start depositing on the kidneys, and there's not much that you can do to prevent that. So it's going to be more supportive care if you have patients with acute glomerular nephritis. All right, I've got 1:47. Why don't we take a 10-minute break and come back, pick up on this slide for lab diagnosis.
Alright, so I was watching
Yeah. I was reading something about where these layers will sleep on the part of this development.
it's real. I swear that is real. Is that John? Yeah, don't mind him. He's an animal. I don't mean to call you.
Like for example, you come and you take the complete.
No, please me. Look.
As he tries to make somebody down,
Oh. Hey, while you're up there, you should take his fucking So you have to watch yourself. What was his middle name? Oh, what country is it?
Yeah.
What was the name of the What was the name of the cadaver? What's the cadaver diet?
For the last 2 years, imagine being right. Trying to keep everybody.
Shaping those pups. Yes, Big Rose. Said, I was talking to Derek. I was like, how do you think she's gonna ask a first order question? Because these are all first order questions. She says they're all gonna be patient presents with this. Because there's no just like straight, what is strep? What is that? Just ask. It's tough. It's gonna be tough. A lot of third order questions coming in this one. Just not just think about what is strep. The patient presents with whatever, what antibiotic is present. There is no antibiotic. There is no antibiotic present. Or antigen. My brain's not braining right now.
Good thing is we have a 4-day before this test. There's no Tuesday test. It's just a Friday test. So you have 4 days to just study this. Yeah.
I think that helps you, though. That gives you more time to think.
That and it gives you more time to say, I got 8 more days until. And my dad's coming down that weekend, so.
I'm gonna lock myself in that room. All of them have a PowerPoint before. It's gonna be the PowerPoint before you.
No, it's like, you know what? This is entertainment. There's it just refreshes me, takes away my headache. You know, time you go.
I'm not going to go home and feel my head $100. So
Teach their own.
I'd be like,
what do I have in a constant higher?
I'm gonna use this like. Use this
By an hour, 5 minutes.
all like notes and stuff.
Then I gotta do that. I do that or something. I don't want to.
Diagnosis on those charts you said like keep.
Just text her
I'll
on
probably
that.
like pull all these off. Somewhere, but then just like use all this as like different sections.
Tomorrow,
Oh, you're asking for
There's only 200 doctor level scientists.
I started to.
Glad I'm not on my way there.
I was not paying attention to any of the documents.
The last lecture was rough.
Which I appreciate because I realized like most of these lectures I don't get it first pass. I gotta go home and back and do whatever freaking I'm going to be saying video.
Know this table.
And
then he asked the slide.
I was like reviewing, like I forgot which one we did, the first lecture, and like I reviewed it, and it's like this 6 lessons. I memorized those things. I completely forgot about those.
Okay guys, so we're still, this is the very last slide on strep pyogenes, but this one we were talking now finally on how we diagnose all these various things that we just talked about. Fortunately, a lot of this just going to be review. Plate. What's the hemolysis pattern? Yeah, good. Microscopy, I think we hit that hard enough, but that second bullet, not useful in pharyngitis or non-suppurative complications. Let's do the easier one of those first. So microscopy, we're talking about gram stains. And you want to diagnose the non-suppurative complications. Probably is no organism if you're talking about one of the sequela. So not going to be able to find anything with a gram stain there. With pharyngitis, so why might that be difficult to diagnose if you have strep pyogenes if you take like an exudate from the tonsils or somewhere in the back of the throat? Yeah, exactly. Like what imagine what's going on in the back of the throat. This is what we'd call a dirty specimen, right? There's lots of different bacteria. And also, it's also a commensal for some people as well. So and there are other organisms that are gram-positive cocci in there as well. So it's not going to be that helpful for diagnosing pharyngitis if you just do a gram stain based off of like a swab of the infected pussy tonsils or something like that. However, you can take a swab of that, put it on a plate, and grow it up, and you can test to see if it has some of these virulence factors that would be a little bit more persuasive that that's causing the problem. So you can culture that. Culturing is nice and it's very sensitive, low amount of organism, not difficult to grow. Strep pyogenes is not fastidious. So you can culture that, and then you can do some rapid antigen tests from those pure cultures, those pure colonies that come out of that plate. Usually that rapid antigen test is going to be considered good enough for a diagnosis, most cases. We talked about the use of serology to look for those antibodies, high antibody titers for anti-streptolysin O, lysine. And as I was talking to somebody on break, in terms of treatment, you do need to treat for strep throat because you want to make sure they don't develop the sequela after fact, right? But for ASTs, these are actually a fairly predictable susceptibility pattern. They are susceptible to penicillins. So as long as your patient doesn't have a pen strep allergy, then first line treatment is penicillin for strep throat. And there are a number of second line treatments that are available as well. Moving on to another species of Streptococcus that has another Lancefield group. But this one is beta hemolytic as well, so that's something in common. They're both beta hemolytic, but this one is group B. The organism is Streptococcus agalactiae, which means in Latin without this particular sugar, lactose. So it probably has something to do with its fermentation profile. But if you've heard of group B strep before, you know it's associated with problems also with pregnancy, but more concerns for the baby than the mother in this case. We'll talk about the natural ecology of GBS, group B strep. About a relatively small percentage of women are colonized in the vaginal tract with this organism. About 10 to 30% of women are colonized. And usually it's just a normal commensal. It doesn't have necessarily all those virulence factors, so you can get along just fine being colonized with group B strep. The problem is, if you have group B strep and you are pregnant and you deliver naturally, vaginal delivery, that baby has a pretty good chance of picking up that bacteria during delivery, and that is what the problem is. That's where you run into issues. The types of problems the baby can have, you can get meningitis, which is extremely concerning, septic meningitis. It's inflammation of the meninges around the brain. You get pneumonia because that baby might be aspirating or inhaling some of that bacteria deep into their lungs. So that can be life-threatening, and you can get septicemia. So those are all really dangerous, concerning conditions. There's an early onset or a late onset, depending on whether this was acquired during delivery. This would be in that first week you'd get symptoms because the baby acquired the bacteria and then it starts replicating. So somewhere in that first week, early onset. And then later, if they develop these serious life-threatening issues later, then they probably picked it up after delivery. So close association with the mother typically, but but not during delivery. Mortality rates are pretty high, 5%, a dangerous thing. And even with the mother themselves, sometimes that can cause infections that affect the mother, endometrial infections. So that's the problem. You've got potentially exposing newborns to this bacteria. How do you think we might mitigate this risk? C-section, yeah, potentially.
And tested for Group B. When you're pregnant, you get tested for Group B and you're vaccinated.
Yes, exactly. So screening, exactly. Yep. This is a very common thing that we do in the United States. We started doing, this is what this data is showing, we started screening women who were pregnant at 35 weeks and then at 37 weeks for carriage of Group B strep. So we'll do a vaginal swab and a rectal swab, and then we'll usually do another one of those really nice rapid PCR tests that give you an answer very quickly on whether or not she's colonized with Group B strep. Take that swab, pop it in the cassette, pop it in the instrument, and do PCR. When we started screening for Group B strep, the incidence of early and late onset invasive GBS plummeted. So that is like our primary mitigation or defense against infants who contract GBS in the U.S. When we do identify mothers who are carriers of GBS, we can put them on antibiotics at least 4 hours before delivery, and that ensures that they get adequate amounts, like the baby is born with adequate amounts of antibiotic in its system. So when it does pass through the vaginal canal, we'll have those antibiotics and we'll be able to survive that infection if it requires it. Strep pneumo, whole other organism. Now we're more or less going back up to, we'll say like head and neck area, I guess you could say. Full name is Streptococcus pneumoniae. Some people refer to it as pneumococcus, you'll hear that. I always say strep pneumo, that's very common as well. This is the one that we were talking about where if you look at the gram stain, it's not going to be in those nice long chains, it's just in those pairs. This is very typical, what it looks like on the gram stain, pairs. If you look closely, this isn't in a huge amount of detail, but diplococci, cocci in pairs. And then as an electron micrograph shows that morphology a little bit more clearly. On a plate, we see these colonies, they have sort of like a little bit of a discolored tinge to them. What do you think for the hemolysis pattern there? Alpha, yeah. So there's a partial breakdown of the erythrocytes there. Oxidation of that hemoglobin that those red blood cells are carrying that gets released causes that greenish discoloration. Strep pneumo is carried in a good percentage of the population, between 30 to 60%, so many of us are colonized, and the primary place where we are colonized with it is in the nasopharynx as well. Oftentimes with no incident or particular risk of infection, but there are some things that can make us more susceptible to infections with our own colonizing bacteria. General debilitation, malnutrition, alcoholism. Common theme, if you're recovering from a viral illness and you do have that damage already, your ability to fight off bacterial infections is limited, so you get secondary bacterial infections from things like Streptococcus pneumoniae. And also if you're asplenic, first of all, what is asplenia? And then what do we know about the spleen in terms of its function? Cleans the blood, right? Filters the blood. So patients who've been splenectomized or asplenic, they've had trauma or damage where their spleen is no longer functioning, they have a hard time, especially with encapsulated bacteria like strep pneumo, and clearing this very difficult to clear bacteria. So they're very susceptible to strep pneumo. In terms of the diseases that can be caused by strep pneumo, which, oh, sorry, I forgot to mention, Lancefield grouping. You guys remember what Lancefield group this has? What's it, Taylor? No, exactly. Yeah, it's not. It does not belong to a Lancefield group. So this isn't. We're not going to call it group this or group that. This is just strep pneumo. Okay. In terms of the diseases it can cause, this is a very, very common pathogen. But on this pyramid here, you can see most of the infections are going to be relatively mild. This pyramid would look different if you're looking at different age populations too, by the way. If you're looking at one for kids, this will have a different distribution versus adults, but this is probably more like what you'd see with adults with strep pneumo. So it can cause a range of different infections. A lot of people are colonized. A smaller percentage of those people who are colonized will go on to get some of these upper respiratory infections. Some minor things that you'll hear about ad nauseum next semester in heat. Things like otitis media, sinusitis, strep pneumo was a major cause of that. Then we can get a little bit more serious than those minor infections and get into things like pneumonia, uninvasive pneumonia. Bad enough, right? That's pretty miserable, especially if you're old or young, it can be fatal. And then you can get invasive pneumonia, where those infected, that infection starts spreading into your bloodstream. That's infected, invasive pneumonia. So that's getting really serious, potentially fatal. And we have full bacteremia, very severe, less prevalent though, and then finally meningitis. That is the most dangerous thing that can be caused by strep pneumo. With meningitis, that too, we oftentimes stratify according to meningitis with adults versus meningitis with kids. When we're talking about meningitis caused by this organism, by strep pneumo, the primary risk is to adults. When we're talking about group B strep, that's a neonatal risk for meningitis predominantly, primarily. We'll talk about some other major bacteria that cause meningitis as well. There's age distribution, so that's something to kind of pay attention to. What's conjunctivitis? I missed that one. Yeah, so bacteria get into your eye and they just cause a little infection of the conjunctiva in the eye. In terms of pathogenesis, so we have our carriers, 30 to 60% of the population who are colonized with strep pneumo. They're fine, but you get establishment and infection sometimes. Establishments, you can have replication and you get more serious infections. Their capsule is important as well. They have a polysaccharide capsule. But the thing about the capsule with strep pneumo is that they have many, many, many different types of polysaccharides. So kind of like when we were talking about strep pyogenes, and you can have like 150 different types of M protein. With the capsule here, you have lots of different polysaccharides. And that makes it also difficult to mount a immune response that would prevent recurrent infections. And that also presents difficulties for people who are trying to develop vaccines against this bacteria. Considering, I'm just going to go back a slide for a second to make this point. Considering the number of people who are killed every year from strep pneumo infections, particularly with pneumonia itself, this warrants a vaccine. We need to have a vaccine against this. So we'll talk about that more in another slide, but and the difficulties there. But that's kind of what this little cartoon is showing you. I apologize, it's not very high resolution, but it's just showing you that your immune system sees one kind of bacteria, strep pneumo. You raise a good antibody response against it, and then you get a second infection that has a completely different antigen that is recognized on the surface. So you have to start all over again. It's very, very difficult. So capsule, major virulence factor, super important for these infections. Over 90 different types of capsular serotypes. It's challenging. They have attachment features that are important for virulence. Have to be able to attach to the upper respiratory tract. What kind of mechanical clearance mechanisms does the host have that will help prevent establishment and attachment? Mucus is an important one. Yeah, what's that called? Cilia. Yeah, there's a mucociliary elevator in your airways. So that's what these bacteria are up against, but that's what they're trying to attach to. They've got to get through the mucociliary elevator and actually bind to those epithelial cells. They also produce a particular kind of protease called an IgA protease. We talked about different subclasses of antibodies before. What are the 5 that humans have?
A, G, M, D.
Good, okay. A, D, E, M, and G. This particular protease will cleave IgA, which is really important for mucosal immunity. Remember that dimeric IgA? So that will help prevent this pathogen from being cleared from those upper respiratory niches. A couple specific enzymes to go over here. We've got two types we haven't really talked about much, particularly this first kind, a little exotic. They're called autolysins or autolysins. I don't know where the emphasis is, which cell level. But what they do is kind of self-destruct their own cell walls. They cause a hydrolysis or weakening of their own barrier, only to the point, like it's a controlled mechanism, only to the point that they can release these intercellular toxins called pneumolysins, which are basically hemolyzins that have a specific targeting function. So with these autolysins, I'll just pronounce them that way, when those autolysins are expressed, they have to be really carefully controlled, and if they aren't, then the bacterial cells just die. It's like, if you know how to drive a stick shift and you don't have that fine-tuned control, it just stalls, right? So it is very common for these bacteria to kill themselves because they're expressing autolysins in the attempt of getting pneumolysins out. What benefit or purpose would it serve the bacteria to get pneumolysins out where they go through all this trouble? What's the benefit? Possibly.
Inhibit immune response.
Any other guesses?
Inhibit immune response?
Possibly. I was thinking more like nutrient acquisition. When you're lysing other cells, that you can get things like iron, which everybody always wants iron, right? So if you're going through the trouble of expressing pneumolysins, that's one major target, nutrient acquisition. There are other effects for expressing these pneumolysins as well. It will help mitigate immune system effectors, things that will stimulate pro-inflammatory cytokines, impair neutrophil chemotaxis, activate the complement system, things like that. And those will contribute to the immunopathology. So, host originating from the host, damage from the host itself. Laboratory diagnosis of strep pneumo. In terms of specimen types, it depends on what infection we're talking about. From the most severe type, meningitis, what specimen type do you think would be appropriate? Cerebrospinal fluid, yep. Septicemia, okay, yeah. And then if you have a patient with pneumonia, sputum or nasopharyngeal swabs. This note about having a negative culture if you collect the specimen post-antibiotic therapy. What's your read on that? Why would that matter? Yeah, so what does a lab need to receive in order to culture viable bacteria, right? So you can get damaged bacteria, and they gram stain all funky, their cell walls are compromised, they won't gram stain purple pink or red, whatever. But you also can have problems actually culturing them, it can be culture negative. So whenever possible, if you can get your specimen collected before you put that patient on antibiotics, that is better for recovering that organism. Like every bacterial pathogen, yeah, it's pretty much, we want the organism in pristine condition so we can recover it and grow it. Yeah.
On the other slide, so
Yeah, it's a general rule, and I think I haven't gone through IPAP, but I think that'll be reiterated once you get into other courses as well. When you're collecting the specimens, do it pre-antibiotic therapy, and then administer your antibiotic. Like, it's not going to delay you by more than a minute or two, right? Just get that specimen off so we have the highest probability of recovering organism from it. Yep. In terms of culture, so we've talked about the alpha hemolytic pattern on there, but the colonies themselves are super mucoid, and that's because they have an usually slimy capsule. We talked about that slimy capsule, but you can see it looks like snot almost on a plate. Very mucoid colonies. Also because they produce those autolysins, those colonies, which would otherwise be kind of small grayish white colonies, tend to be flattened when they're producing autolysins. Just a consequence of that toxin. The quill-lung reaction, this is unique and distinctive for strep pneumo, and it's also a consequence of the capsule. We have specific antisera that we can buy, and you mix it in with a colony from a plate where you've grown your strep pneumo. And what it does is the antisera, the antibodies in the antisera will bind to the capsule and cause it to expand. So that's called the quill-lung reaction, and it just gives you an indication that you have an encapsulated strain. You can see it very easily when you do microscopy. And then with PCR, particularly useful if you were not able to culture the organism, like if you've already prescribed antibiotics, for example, and you don't have viable organism. What's the nice thing about PCR?
Nucleic acid.
You're detecting DNA, right? You don't have to have the organism intact to detect DNA. Eventually it will degrade and you'll lose all target, but you can detect, it's very sensitive, so you can detect a small amount of DNA from an organism that's been killed by antibiotics. All right, with vaccines, a couple things to note here. As I said, this is super important to develop a vaccine for strep pneumo, particularly because of the bacteremia and the pneumonia and the meningitis. But there's a problem because the type of humoral immunity you're trying to raise is against that stupid polysaccharide capsule, right? And because you have all those different types of polysaccharide capsule. So we know a thing or two about what antibodies prefer to bind to, don't we? What's the best macromolecular structure for them to bind?
Proteins.
Protein. And then after that, carbohydrates, yeah. And at the very bottom, we have lipids. They don't do well at all with lipids. So we're dealing with a big time, a saccharide or carbohydrate target. When you can raise antibodies against a polysaccharide capsule, but there's going to be some affinity issues, and there's also going to be some issues if you're talking about an artificial vaccine, and that's the only thing that the immune system is seeing. There's going to be some issues with the way it activates the immune system. You're going to get a crappy immune response. So that we developed this vaccine based off of polysaccharides alone, but the good news is it was a high valency, which means it could encompass 23 different polysaccharide serotypes that were commonly circulating. So we covered a lot of bases, but the bad news is the crappy immune response. It wasn't that protective. And that's because when you have a carbohydrate-based immune activation, you don't necessarily get that really robust activation of B cells. So you don't have affinity maturation, and you don't have development of memory B cells. So it's not going to last that long, and it's not going to be that good. That's a big problem. You might have to get revaccinated a couple times. Adults are better at mounting a good immune response or a better immune response to these polysaccharide antigens than kids are. Kids, you essentially cannot vaccinate them. They don't have the ability to do this T-cell independent activation route. So because of that reason, we had to do a little workaround and conjugate a protein to that polysaccharide vaccine that would make it more immunogenic and stimulate a T-cell response. That's a T-cell dependent vaccine response. The protein that we ended up using to conjugate it to, we had a couple. One was from diphtheria and one was from tetanus. So the toxins from Corynebacterium diphtheriae and Clostridium tetani were made into toxoids, deactivated by formaldehyde, and then conjugated to those polysaccharides. And then you got a totally different vaccine, which was called the pneumococcal conjugate vaccine. So that stimulated a much better immune response because of that protein conjugated adjuvant. And it was able to be used in kids, which is really important because kids can get these, are susceptible to these infections as well, as you know. That came on the market in 2010. The trade-off is you don't have as many serotypes that are covered. There's only 13. That's why it's called PCV13. It's pneumococcal conjugate vaccine 13. Okay, but with the adult vaccine that's crappy, we have 23 different capsid types. Make sense? Okay. So now we're going to skip over to a different genus next, and we'll come back to strep, finish off with strep. But the only reason why we talk about Enterococcus now is because it does have that Lancefield group, and it behaves in a lot of ways like some of these other strep species. So it fits in well here. So again, these are group D reactive organisms, the Enterococci. They can have any number of chemolytic patterns, so you can't really hang your hat on what that looks like when you culture these things. There are many species of Enterococcus, but Faecium and Faecalis are the two most important ones. The genus name Enterococcus, what does entero suggest to you in terms of where it likes to live? Its habitat. Intestines. And then Faecium and Faecalis, what does that sound like? Yeah, so these are commensals of your GI tract, both of them. And usually they're just that, they're just commensals, but they can be problematic for a couple of reasons that we'll get to in a second. Sort of like when we were talking about with some of with staph, their virulence properties are similar to, they have attachment capabilities and they too can form biofilms. If you look at a gram stain of these guys, they look a lot more like strep than they do staph, although they tend to be shorter chains than a lot of your streps. They don't produce a lot of toxins, but they will produce some proteases and some hemolysis, so some strains do and some strains don't. That's why you have the variable hemolytic patterns here. Okay, in terms of epidemiology, this might be species dependent or not, but we talked about the GI tract being colonized. Perhaps some of these species can colonize the oral cavity as well. Where we are really concerned are with hospital-acquired infections. They are able to persist out in the environment for longer periods of time. And they do tend to be more resistant to environmental and chemical agents. So there's a concern for fomite transmission there. The number and types of infections, we're not going to go into the pathology and discuss the pathogenesis of all these different infections. Just kind of know straightforward that these are in the retinue, they're capable of causing these different infections. Antibiotic resistance is a big concern with Enterococci. You guys remember when we were talking about the Van A, Operon, and Versa with Enterococcus playing a role in that? Yeah, so Enterococcus, when they're in your GI tract and they're commingling, or in your oral mucosa, and they're commingling with other types of bacteria, they can spread and share those antibiotic resistance genes via plasmid transfer. Okay, so they're big sources of those issues as well. In terms of resistance, we do have some ultra-resistant strains of Enterococci out there that are super concerning. These would be on the list of escape pathogens. So there were 2 E's. One of those E's in escape is Enterococci. Vancomycin resistance is particularly concerning. And when they have vancomycin resistance, this is usually something that they are acquiring. So they're not intrinsically resistant to it. They acquire it through transfer of plasmids. I kind of made a mistake when I was formatting this slide, and I should have bumped these bullets over, but vancomycin is one, vancomycin resistance is one facet of how they're resistant. And I didn't want to conflate that with other classes of antibiotics. So you probably know this, but cephalosporins they target cell wall synthesis as well, right? But not in the same mechanism. So this is different than vancomycin resistance. This is its own type of resistance. Intrinsic resistance to, yes, sir. Yeah. No, it's so not multiply, but multiply, as in or multiply resistant as opposed to singly resistant to. And that is a good note. I should have glossed over that. Faecium is significantly more resistant. Those isolates tend to be more resistant to vancomycin. So intrinsic resistance to cephalosporins simply means that they have intrinsic resistance. They are always going to be considered to be resistant to cephalosporins. What category of antibiotic did cephalosporins fall under? Beta-lactams, exactly. Yep. Then we had aminoglycosides, high level, meaning that not dose dependent. It just, you can dose it all day long with aminoglycosides. They are going to be resistant to that. There's no intermediate level resistance there. I'm not sure what the mechanism is, but whatever it is, it's robust. you guys remember what target aminoglycosides had as an antibiotic class? 30S, ribosome subunit, outstanding, good job. And then lastly, carbapenem-resistant enterococci. You'll see VRE a lot for vancomycin, and you'll see CRE a lot for carbapenem-resistant enterococci. What major class did carbapenems belong to? Beta-lactose as well. Yep, good job. All right, almost done. Moving back to the streps, we're just going to round out and finish the last couple of clinically important types of streptococci. Group C strep, Streptococcus dysgalactiae, is important. It behaves a lot like group A strep. You can basically think, if you look at this list of issues that are associated with group C strep, you'll see a lot of things that we talked about already when we were talking about Streptococcus pyogenes. Tonsillitis, like strep throat, superficial skin infections, cellulitis, erysipelas, soft tissue infections, severe necrotizing fasciitis, osteomyelitis, arthritis, pneumonia, enteritis. All of that can be caused by group A strep. So, if you have a patient and you think they have something serious like this, and you submit for testing, and it comes back, and you think it might be Streptococcus pyogenes, so it looks like grandpa's cocci and chains, but the anti-sera doesn't mix when you do your Mansfield testing, try group C. Okay. Also beta hemolytic, so virtually identical. And then the last one on this slide is group D. This would be having the same C substance as those enterococci. Streptococcus bovis, which actually has been reclassified. I think it's now Galolyticus. It's been renamed, but whatever. This too is a normal commensal. It's a gut bacterium. It causes a smaller number of infections, just bacteremia, endocarditis, and UTIs. And this can have some variable hemolysis patterns depending on which toxins are expressed by those different strains. Lastly, we are finally getting down to the viridins streptococci. Viridins, again, from the Latin meaning green, alpha hemolytic, partial breakdown of red blood cells in blood agar. Again, this was not a species, this is a group. So we have mutans, salivarius, anginosus, mitis, and synchronous. A bunch of different species in this group that's referred to as viridins. They all behave very much in the same way, but they are different species, okay, but they have a lot of similar characteristics. Alpha hemolytic, normal commensals in the oral cavity, upper respiratory tract, and in the vaginal tract. Tend to have less antibiotic resistance, with the exception of Streptococcus mitis. And kind of like when we were talking about with some of those coag-neg staph, most of these tend to have less virulence, but that doesn't mean they can't cause some of these issues. These issues too, there's not much for me to talk through or explain here. They're pretty straightforward, so don't really need to go through the pathogenesis. Just sort of be familiar with the fact that they can cause these different types of infections. Biofilm formation is super important with these as well. And then this note about dental procedures, particularly with Streptococcus mutans, is important to know too. When you have dental procedures, oftentimes if you've ever had them messing around in your mouth there, even if they're doing a routine cleaning, you can have abrasions in the gums and a little bit of bleeding. You have a lot of bacteria in your mouth. So everything from like a normal cleaning all the way up to invasive, serious dental work predisposes you sometimes to some of these bacteria that are in your oral cavity anyway. That's the major concern. And then with mutans, dental caries, that's like an erosion of the enamel on your teeth, so that's a little bit different. That is it for this deck. We made it all the way through. Any questions for me about Streptococci? Okay, all right guys, this hand. Which that's the one with the higher valence. The higher number is the adult one. So PPSV 23. Say again. Or T-cell dependent. Okay, guys, I will be around for a little bit. Some of you still want to talk about your exams down in the office. That's totally cool. I'll, meet with a couple of you if you want. Have a wonderful 4-day. I know you're getting slammed with an exam on Monday, but it's nice to have a 4-day weekend. You guys deserve it. So.